Hi and welcome. This is an informational presentation on interprofessional collaboration between nurses and speech-language pathologists who manage patients with dysphagia, which means problems with swallowing foods, liquids, or medications. The presenters are Megan Saxon, Jackie Katsev, Rachel Plavnik, Rachel Strachko, and Ellen Rudinsky. We are graduate students in the speech-language pathology program at Salus University. This presentation is being done as part of our capstone project. We would like to extend a special thank you to Salus University and Dr. Amy Lustig, PhD, CCC, SLP, for supervising our graduation capstone project. Interprofessional education. ASHA's definition of interprofessional education, or IPE, is an activity that occurs when two or more professionals learn about, from, and with each other to enable effective collaboration and improve outcomes for individuals and families with whom we serve. Interprofessional collaboration is virtually important to help improve the services we provide for each of our patients and increase the knowledge that we have about other professionals and their roles. Significance of interprofessional education. According to the World Health Organization 2010, interprofessional education can enhance health services, improving patient outcomes. Interprofessional education promotes opportunities for students to interact and learn the roles and responsibilities of their future colleagues. More than 80% of RNs, included in a study by McCullen and colleagues in 2007, reported an interest in more education on dysphagia. However, at least 72% of RNs in this study reported their training on swallowing disorders was from on-the-job experience rather than information they'd obtained during their education. Another study, conducted by Gassimi and Fabus, 2017, examined the collaboration of undergraduate nursing students and SLP graduate students, focusing on their roles in the management of patients with dysphagia. They were given an educational lecture that highlighted the importance of collaboration. These results indicated that each professional group increased their knowledge on post-test measures. These results indicate positive results for collaboration between SLPs and nurses. However, Hodge, Nordine, Brad, and Ofsted, 2015, reported that while nursing training programs recognize the need to incorporate this education, few actually implement them into their busy curriculums. Nurses are the frontline providers for the patient when they are admitted to a hospital. They are the ones who spend the most time with them out of the hospital staff. This is essential when it comes to dysphagia because they are able to refer patients to see a speech pathologist or SLP when they suspect they are seeing signs and symptoms of dysphagia. Nurses also need to have some knowledge about feeding procedures to be sure that the patient is getting the best feeding care. Nurses and speech pathologists work collaboratively for patients with dysphagia to ensure they are receiving the best possible care. Our learning objectives. Today we will define what a speech pathologist is, define what dysphagia is, we will review the swallowing mechanisms and the stages of swallowing, discuss swallowing dysfunction, discuss signs and symptoms of aspiration, define aspiration pneumonia, and discuss the nurse's role in dysphagia management. What is a speech-language pathologist? A speech-language pathologist is a professional who works to prevent, assess, diagnose, and treat speech, language, social communication, and swallowing disorders across the lifespan. What is dysphagia? Dysphagia is difficulty in swallowing. This word is derived from the Greek root phagein, which means to ingest or engulf. Different types of dysphagia can include feeding disorders, swallowing disorders, and eating disorders. A feeding disorder usually results from weakness or incoordination in the hand or arm that is used to move the food from the plate to the mouth. This is usually addressed by an occupational therapist. A swallowing disorder usually results from weakness or incoordination of oropharyngeal or esophageal musculature. These impairments are typically addressed by a speech-language pathologist. Eating disorders are usually considered to be psychological in nature. These include anorexia or bulimia. Anorexia is characterized by an obsessive desire to lose weight through refusing to eat. Bulimia can include distortion of body image and an obsessive desire to lose weight, where bouts of extreme overeating are followed by depression and self-induced vomiting, purging, or fasting. Individuals with eating disorders are usually managed by psychologists or other mental health providers. Prevalence of dysphagia. The true prevalence of dysphagia in the adult population is unknown. However, reports show at least 1 in 25 adults will experience some degree of swallowing dysfunction. Bhattacharya, 2014. The National Foundation of Swallowing Disorders reports the prevalence of dysphagia may be as high as 22% in the adult population age 50 and older. ASHA, 2019. Approximately one-third of patients with swallowing dysfunction develop pneumonia, which may lead to about 60,000 deaths per year. The Agency for Healthcare Policy and Research, 1999. And at least 68% of individuals in long-term care facilities are diagnosed with some degree of swallowing dysfunction. Steele and colleagues, 1997.
Consequences of dysphagia. Since swallowing is difficult and often unpleasant for the patient, lack of nutrition is common due to the patient's inability to ingest and then digest food and liquid. Certain foods may be off limits for a patient with dysphagia. Examples may include dry, crumbly foods, such as crackers or bread, tougher foods such as meats or mixed consistencies, or solids with liquids, like cereal and milk or soup. If the dysphagia is severe enough, the patient may be instructed to take nothing by mouth, often referred to as NPO, which stands for nil per os, which means that the patient is unable to consume anything by mouth. In which case, the patient may be placed on a feeding tube, such as a nasogastric tube, in order to receive nutrition. Dehydration is often common, as patients with dysphagia may not be allowed to drink water and need to rely on thickened liquids, which are not as hydrating as water. If they cannot drink properly, then their fluid intake may not be as sufficient. Aspiration pneumonia may occur when small amounts of food or liquid travel into the area and reaches the lungs. The topic of aspiration pneumonia will be discussed in a later slide. If an individual is unable to swallow food safely, a piece of food may get stuck in their throat, which can ultimately lead to asphyxiation, as their airway is blocked off. Patients with dysphagia often report a decreased quality of life, as social situations often revolve around eating in restaurants, which patients may avoid due to their inability to properly eat and swallow food. The swallowing mechanism. During swallowing, the soft palate and uvula move upwards, which prevents food and liquid from going into the nasal cavity. The oral cavity is comprised of the teeth, tongue, hard palate, and soft palate. The teeth aid in the mastication of food, while the tongue pushes the bolus, which refers to what is being swallowed, against the hard palate and then down into the throat. The pharynx is comprised of the nasopharynx, oropharynx, and hypopharynx. The nasopharynx is the space above the soft palate at the back of the nose and connects the nose to the mouth, which allows a person to breathe through the nose. The oropharynx serves as a passageway for food, moving from the mouth to the esophagus and for air moving to and from the nasal cavity. The hypopharynx is the lowest part of the pharynx and is divided into 3 regions: piriform sinus, postcricoid region, and the posterior pharyngeal wall. The epiglottis is a flap of cartilage that covers the larynx and prevents food from entering the wrong pipe. The larynx or voice box contains the vocal folds and sits at the front of the neck. It plays a role in sound production and is also the entrance to the windpipe. The trachea, or windpipe, is a tube that connects the larynx to the bronchi of the lungs. Airway protection during swallowing is critical to prevent food from passing through the trachea, bronchi, and lungs, which could ultimately lead to pneumonia. When food is successfully swallowed, it passes through the esophagus into the stomach to be digested. This is an anatomical view of what happens during a successful swallow through a modified barium swallow study. The patient is given a liquid or solid containing a small amount of barium. During the X-ray, the barium is visible, which allows radiologists and speech-language pathologists to see what is happening in the oral cavity, pharynx, or esophagus, and the activity of the muscles. Different types of dysphagia. Oral dysphagia refers to problems with using the mouth, lips, and tongue to control food or liquid. These problems can include difficulty chewing solids and holding liquids within the oral cavity. Patients with oral motor difficulties may experience discoordination and weakness of tongue movements. Oral dysphagia may also include loss of food from the mouth, which may result in difficulty maintaining nutrition. Patients with dementia may also exhibit oral dysphagia by holding food within the oral cavity. Pharyngeal dysphagia refers to problems in the throat during swallowing, which may include difficulty in triggering the swallowing reflex. Due to weakened throat muscles, residue or pieces of food may also be left in the throat, which could be aspirated later on. Esophageal dysphagia refers to the sensation of food sticking or getting hung up in the base of your throat or in your chest after you've started to swallow. The feeling of getting stuck is known as a globus sensation. Individuals may experience this due to the narrowing of the lower esophagus. Gastroesophageal reflux disease, or GERD, where stomach acids move back up into the esophagus, may also cause individuals to experience esophageal dysphagia. Swallowing stage 1, the oral phase. During the first stage, the tongue collects the food or liquid, turning it into a bolus and making it ready for swallowing. The tongue and jaw move solid food around in the mouth and coating it with saliva, so it can be chewed. Chewing helps make solid food the appropriate size to swallow. Saliva aids in softening and moistening the food to make swallowing easier. Swallowing stage 2, the pharyngeal phase. The pharyngeal phase starts when the tongue pushes the bolus to the back of the mouth. A swallow response is triggered, which passes the food through the pharynx or throat. During this pharyngeal phase, the larynx closes and breathing is halted momentarily to prevent food or liquid from entering the trachea or airway and lungs. Swallowing stage 3, the esophageal phase. The esophageal phase begins when food or liquid enters the esophagus. This course through the esophagus occurs in about 18 to 20 seconds, but can take longer in other situations, such as when swallowing a pill.
Swallowing dysfunction in the oral stage. There are several things that can occur during the oral stage that reflect swallowing difficulties. The first thing that can occur is that the patient may not be able to hold food or liquid in their mouth. This can be due to labial weakness, lip weakness, resulting in reduced closure around a spoon, fork, cup, or straw. Patients can also have difficulty forming a bolus. This can happen when a patient has uncoordinated or weak oral muscles. Next is residue in the oral cavity. This commonly occurs with patients who have left or right-sided weakness of the muscles in their tongue and cheek. This weakness can make it harder for the patient to collect food or liquid on the weaker side of the oral cavity. Patients can also exhibit prolonged mastication or chewing. This can occur in patients who have weakness or poor coordination of their jaw muscles or difficulty focusing their attention on the task of chewing. Another dysfunction which may or may not put the patient at risk for aspiration is reduced oral control of the bolus. This is when food or liquid spills into the pharynx before the patient began to swallow. This may be due to reduced coordination during the swallow. Swallowing dysfunction in the pharyngeal stage. Problems with swallowing can also happen during the pharyngeal stage. One thing that can occur is nasal regurgitation, which can happen when there is weakness in the muscles of the velum or soft palate. In this situation, the nasal cavity will not be completely closed off, and food or liquid may enter the nasal cavity and may leak out from the patient's nose. A patient with dysphagia could also have a delayed or absent swallow reflex. A delayed swallow reflex refers to when a person's automatic swallow reflex triggers later than typical. An absent swallow reflex is when the swallow reflex is not triggered at all. If a patient's swallow reflex is absent, then food, liquid, and saliva would not be able to enter the esophagus, which could put the patient at risk for aspirating. Patients without a swallow reflex are considered NPO for their safety. Food or liquid particles can sometimes enter the airway at the level of the laryngeal vestibule, which is above the larynx. This is considered laryngeal penetration if it stays above the level of the vocal folds. If the food and or liquid goes below the vocal folds and is at risk for entering the lungs, this would then be considered aspiration. If patients have reduced muscle strength in the pharynx, They may have residue or bolus debris adhered to the pharyngeal wall, or pooled in the molecular space, which is the bilateral pockets found between the base of the tongue and the epiglottis, the laryngeal vestibule, which is the area above the vocal folds, and or in the piriform sinuses, which is the bilateral pockets located directly above the UES. Now we will show you a brief video showing what a video fluoroscopic swallow study looks like. This one in particular is showing a patient with Zenker's diverticulum, which will be discussed in the next slide. Swallowing dysfunction in the esophageal stage. When there are swallowing problems at the level of the esophagus, the patient will typically be referred to a gastroenterologist for further management. Patients could have a great deal of difficulty passing the bolus through the upper esophageal sphincter, the UES. This can happen when someone has reduced laryngeal elevation or when the muscle of the UES is tighter than normal. Patients can also experience backflow of food or liquid from the esophagus into the throat, which is known as gastroesophageal reflux disease, or GERD. A patient can also have formation of diverticulum or tracheoesophageal fistula. A common diverticulum is Zenker's diverticulum, which was briefly discussed in the previous slide. This is when a sac or a pocket forms in the pharyngeal wall due to muscle weakness. Food and liquids can collect in this area, which can be very detrimental for a person. There can be risk for aspiration on the contents in the diverticulum. Modified barium swallow. One tool SLPs use in the hospital setting is the modified barium swallow, also known as a video fluoroscopic swallow study. This instrumental study is done in radiology and uses fluoroscopy through which we can view the oral, pharyngeal, and esophageal phases of a patient's swallow and to describe any functional impairments associated with changes in strength, range of motion, or coordination that are negatively affecting the patient's swallowing competence. Trials of various food consistencies and liquids are performed during this study in a controlled way by the SLP. In the first video, you see a study of a normal healthy swallow. The person is drinking thin liquids from a cup, followed by pureed texture. The person then eats a cracker with barium on it. You can see the bolus flows smoothly and rapidly from the oral cavity into the pharynx and then down into the esophagus. Towards the end of the video, you can see imaging from the front where the bolus enters the stomach. You can also see the liquid go down into the esophagus where you can see esophageal motility. The second video shows a study where the patient is observed to aspirate during swallowing trials. As a reminder from the anatomy slide, the larynx is in the front and the esophagus is in the back towards the spine. You can clearly see the liquid going down and underneath the epiglottis and below the vocal folds in this video. The liquid has clearly entered the airway. Of note, there is residue left under the base of tongue, which will likely be directed into the airway after the swallow if there is poor sensation as well. Aspiration and aspiration pneumonia. The term aspiration is meant to reflect that liquid, food, or secretions have penetrated below the vocal folds during the process of swallowing and are likely to enter the lung. When a patient aspirates, this can lead to aspiration pneumonia. This is when food, liquids, or secretions from the mouth or stomach enter the lungs and cause a pulmonary infection. Aspiration pneumonia is one of the most common types of infections in hospitalizations, and Langmore et al. 1998 found in nursing homes it ranges from 13 to 48% of developed infections. The two pictures on the right are examples of FEES images. FEES stands for Fiber Optic Endoscopic Evaluation of Swallowing, which is another tool that SLPs use to evaluate a patient's swallow. During a FEES, the patient is given different consistencies of food and liquid to examine what happens during their swallow. Typically, The food and liquid are dyed so that they are more visible, which you can see in the pictures. In both pictures, you can see that the residue has entered the laryngeal vestibule and has passed through the vocal folds. In the top picture, you can see green dyed pureed food, and in the bottom picture, blue dyed thin liquids in between the vocal folds and in the trachea.
Various diet consistencies may be recommended by the SLP. Commonly used names for various liquid consistencies include honey-thick liquids, which are tested by placing a spoon in the cup and seeing if it will stand up straight for 1 to 2 seconds. Nectar-thick liquids, where the liquid will slowly drip off a spoon, and regular everyday liquids, which are referred to as regular thins. The solid consistencies are puree, which is completely smooth, ground, which has some texture. Minced and chopped foods are similar, however minced is slightly smaller cut pieces. Mechanical soft items are selections of softer, moister food from a regular diet, and regular solids are everyday foods. An SLP will recommend the least restrictive diet that maximizes safety and access to sufficient calories and fluids. Diet modifications and potential for advancing the diet is considered on a regular basis as dysphagia therapy is provided, with the meeting patient preferences while keeping them safe and healthy. There are various companies that produce pre-thickened liquids which may be used in various hospitals, rehabs, or skilled nursing facilities. There are also options available for nursing staff to thicken liquids using products which may come in powder or gel form. There are instructions on the thickener containers regarding how much of the product is required for each consistency. If you are ever unsure about thickness regulations, please ask the SLP working at the facility. It is important to note that the longer these thickened liquids sit at bedside, the thicker they become. So it's important that the patient's liquid is thickened directly before they will be drinking it. Also, thickened beverages generally taste better when they are cold or chilled. When a patient has known dysphagia, there are a number of things that the SLP may do aside from modifying the consistency of their foods. The SLP may try some postural changes or strategies to decrease the chances of penetration or aspiration. When trying different postures, this may be done during the MBS study to see if the postural changes are effective. Some of these postures may include a chin tuck, a head tilt, or a head turn. Not all patients will benefit from a postural change when swallowing, though sometimes it can significantly improve the safety of the patient's swallow. An SLP may try some strategies when seeing how to increase swallowing safety. For some patients, strategies such as a double or multiple swallows, swallowing more than once for each bite or sip, can help when food gets stuck in the pharynx, or using small teaspoon-sized sips will significantly reduce penetration or aspiration during a follow. In order to rehabilitate the swallow and to help strengthen the muscles we use when we swallow, there are different exercises that SLP may use with a client. As with all exercises, consistency and increased intensity are important. Do not recommend any postural changes while swallowing unless it has been cleared through the speech therapist, as sometimes postures such as a chin tuck can actually make the swallowing worse. Nurses are available to patients 24 hours a day. As such, there is much more communication and contact between nurses and their patients than between other professionals and patients in the healthcare setting. Because of their frequent proximity to patients, nurses may be able to play a substantial role in reducing the risk of certain adverse events, including those to do with management of patient with dysphagia. This is why it is so important to educate nurses about what we do and why we do it. Occasionally, and in some facilities or hospitals, nurses are asked to complete an initial dysphagia screen as part of the patient intake process. When completing a dysphagia screen or otherwise interacting with patients, nurses must have awareness of the signs and symptoms of aspiration which were discussed earlier. Nurses are often the first to notice if a patient is having difficulty eating or drinking and have responsibility to determine whether an SLP consult is indicated. Certified nursing aides are usually the frontline responsible staff for providing feeding assistance to patients with dysphagia, as recommended by the SLP. The RN is responsible for these patients, also needs to be aware of all the diet modifications and safe swallowing strategies that have been recommended. The certified nursing assistant and RN should also Be alert to the possibility of errors on food trays and prevent any wrong items from being consumed by the patient. Nurses need to know about any recommendations for modifications and how medication should be administered to patients with dysphagia. Not all patients are able to swallow pills with water. Some require medications crushed in puree or take medication one by one with small single sips. When feeding a patient, it is important to be aware of their positioning. Patients should be fed when seated upright at 90 degrees. If possible, it is preferred for the patient to be out of bed in a chair when eating. For safest eating, the following are advised. Make sure the patient is awake and alert. Take small bites and sips. Use slow rate of intake. Minimize distractions such as talking while eating. And provide verbal encouragement to chew and swallow if the patient appears to be distracted. Oral care is extremely important, especially for patients who cannot perform oral care independently. Oral care can be a contributing factor in the development of aspiration pneumonia. Some patients may aspirate their own secretions. If there is a bacteria in their mouths which can result from poor oral care, the patients will be aspirating this bacteria, which can manifest into a respiratory infection. Unfortunately, poor oral care is common in the hospitals and nursing homes. This is because some patients may not be able to do it themselves and the staff is busy with other tasks and do not prioritize oral care. Oral care may be overlooked as an important factor in many patients, especially those who are NPO. It is important to remember that sufficient oral care is needed to reduce bacteria in the mouth and therefore reduce the risk of infection. Some basics of oral care recommendations are completing oral care 4 times a day for patients that are NPO. This may be done with swabs or a regular toothbrush and mouthwash. Oral suction may also be used.
Frazier Free Water Protocol allows certain patients who are NPO or on thickened liquids to have the option of drinking thin liquids and or ice chips between meals despite being identified as being at risk for aspirating thin liquids. This protocol was developed to provide patients with dysphagia the option of drinking water in between meals when on a modified diet such as thickened liquids. There is a specific protocol to follow. The Frazier Free Water Protocol is not appropriate for all patients. The SLP will determine if a patient is an appropriate candidate and will collaborate with the RN. The guidelines for the protocol are: patients may drink water only before and after meals, not during. Oral care must be completed prior to water consumption. Patients must sit upright and use appropriate swallowing strategies. Gilman, Winkler, Taylor, 2017 conducted research which demonstrated the Frazier-free water protocol did not result in an increase of aspiration pneumonia in patients. Patients reported having a better quality of life on this protocol. The researchers found water to be safer to aspirate than thickened liquids because water contains less pathogens than other liquids and small amounts of water can be reabsorbed into the lungs. As stated previously, in some facilities or hospitals, nurses may be asked to complete an initial dysphagia screener. The next few slides represent an example of an initial swallowing screener used at the Hospital of the University of Pennsylvania for nurses, which is completed prior to SLP consult. The screener was created by Randy Dubin, a speech pathologist. The screener consists of 3 parts and a results section. Part 1. Pre-screen assessment. Check all that apply. Patient has both facial droop and slurred speech. Patient has history of dysphagia. Patient has wet voice or is unable to manage secretions. Patient has a tracheostomy or feeding tube. Patient has active speech orders. Patient intubated more than 48 hours or multiple intubations without prior ICU screen. If any checked, do not proceed, keep NPO, notify MD, and request SLP consult. Part 2. Psychomotor level of consciousness respiratory assessment, which will be answered with either a yes or no. Is the patient consistently alert? Is the patient able to sit upright? What is the patient's O2 saturation level and resting respiratory rate? If response is no to any item, stop, keep NPO, and notify MD. Part 3. 3-ounce water swallow test. Instructions. Tell the patient to drink continuously from cup without sipping. May use straw if patient unable to self-feed. For 1 minute after drinking, monitor for the following and check all that apply: coughing, throat clearing, wet, gurgling voice, loss of fluid from mouth or dribbling, oxygen desaturation or shortness of breath, delayed, difficult, painful swallow, tearing with swallowing effort, patient unable to drink continuously. Results. The patient either passes or fails. Pass, proceed with diet per MD. Fail, keep MPO, request SOP consult, and discuss with MD if there is a need to complete the Puree challenge for critical medications. The Puree challenge is used to determine candidacy for PO meds crushed into puree. Offer half a teaspoonful and a single teaspoon of applesauce or pudding. No difficulty noted. Discuss with MD if meds may be given crushed in puree. Difficulty noted. Just check all that apply. In conclusion, speech-language pathologists work with a variety of patients in the medical setting and are responsible for evaluating and managing patients who present with swallowing difficulties. SLPs may recommend modified diet textures and PO intake strategies to maximize nutrition, hydration, medication intake, and minimize risks. These risks include aspiration, choking, and other adverse events. Nurses need to be aware of recommendations for modified diets and intake strategies and to communicate any concerns to the SLP. Management of dysphagia offers opportunities for collaborative care between nurses and SLPs. In their article on interprofessional collaboration between nurses and speech pathologists for patients with dysphagia, Dondorf, Fabius, and Gahasi 2015 reported on several ways that SLPs and nurses can interact to maximize patient outcomes. These include the provision of in-service trainings by SLPs for facility nursing staff and educational updates for administrators of both services. The authors also suggest the development of multidisciplinary professional trainings and collaborative goal setting to address both evaluation and management of patients with dysphagia, and the roles that both nurses and SLPs play across these domains of care. Thank you for your time and attention to this information in the video. We look forward to our future collaboration with nurses.